The legacy of pirate medicine is not a story of heroic breakthroughs or direct inventions that shaped modern surgery. It is a quieter, more practical inheritance, rooted in the brutal necessity of working without a safety net. The pirate surgeon operated in an environment where failure was immediate and fatal, and this pressure forced a certain kind of pragmatism. While the formal medical establishment of the 18th century was often slow, theoretical, and bound by tradition, the ship surgeon had to be quick, resourceful, and willing to try anything. This practical, evidence-based approach, born of desperation, laid some of the groundwork for later advances in emergency medicine, naval hygiene, and the standardization of surgical procedures. The most direct legacy lies in the field of trauma surgery. The pirate surgeon's need for speed and efficiency during amputations was not just about cruelty. It was a clinical response to the realities of shock, blood loss, and infection. The techniques they refined, the use of the tourniquet, the methodical cutting and sawing, the careful ligature of arteries, became the standard for military and naval surgery for generations. The emphasis on speed directly influenced the development of battlefield surgery, where the same constraints of time and environment applied. The surgeon's kit, with its organized, purpose-built instruments, was a precursor to the modern surgical tray. The idea that a specific set of tools should be laid out in a predetermined order for a specific procedure was a significant step away from the general practitioner's bag of mixed remedies. Beyond the operating table, the management of disease on long voyages forced a crude form of epidemiology. Ship logs and surgeons' reports provided a growing body of observational data. When a crew member fell ill, the surgeon noted the symptoms, the timeline, and the conditions. When a whole crew was struck by scurvy, the pattern was undeniable. These observations, compiled over decades, created the foundation for James Linn's landmark clinical trial in 1747, where he demonstrated that citrus fruits could cure the disease. Linn's trial is rightly celebrated, but it was built on the accumulated anecdotal evidence gathered by countless ship surgeons who had noticed that men who ate certain foods seemed to survive longer. The pirate surgeon, in his desperate search for anything that worked, was an unwitting contributor to the science of nutrition and preventative medicine. The failures of pirate medicine are equally instructive. The persistence of bloodletting, purging, and blistering, despite their obvious harm, demonstrates how deeply entrenched a flawed theory can be. The surgeon's chest contained both effective remedies like Peruvian bark and deadly ones like mercury. The lack of understanding of germ theory meant that even the most skilled surgeon could not prevent infection. The high mortality rate from simple wounds was a direct consequence of operating in a non-sterile environment. This grim reality forced a later generation of surgeons, like Joseph Lister in the 19th century, to search for a way to prevent infection. The problem that the pirate surgeon could not solve became the problem that revolutionized modern medicine. The concept of triage, the sorting of patients by severity of injury, was also a practical necessity on a pirate ship. With limited supplies and a single surgeon, decisions had to be made about who could be saved and who could not. A man with a minor cut was treated quickly. A man with a shattered leg and a fever was given rum and time, but if he did not improve, resources were not wasted. This brutal calculus is still the foundation of emergency medicine and battlefield triage today. The modern emergency room, with its trauma teams and prioritized care, is a direct descendant of the pragmatic decision-making that happened in the dim light of a ship's cockpit. The legacy is also found in the evolution of naval hygiene. The connection between cleanliness and health was observed, even if not understood. Surgeons who insisted on scrubbing the decks with vinegar, or who aired out the sleeping quarters, were practicing a form of sanitation that reduced disease. These practices, refined over centuries, became the standard for navies and eventually for public health. The pirate ship, a floating petri dish of disease, became an unintentional laboratory for understanding how to keep a closed community healthy. The lessons learned about ventilation, diet, and waste disposal were directly applied to prisons, factories, and eventually cities. In the end, the pirate surgeon left no textbooks, no formal schools, and no celebrated medical discoveries bearing his name. His legacy is written in the procedures that became standard, in the observations that seeded new sciences, and in the enduring principle that when life is at stake, theory must yield to practice. The modern surgeon, working in a sterile operating room with advanced tools, owes a debt to that desperate figure in the dim, rocking cockpit, working by lantern light with a saw and a bottle of rum. The tools changed, the knowledge expanded, but the core challenge remained the same: to preserve life in the face of overwhelming odds. The pirate surgeon's toolkit, crude as it was the first step on a long road. The pirate surgeon's arsenal was a study in grim necessity. Its contents can be broadly divided into three categories: the instruments for cutting and sawing, the materials for sewing and dressing, and the pharmacological agents for treatment and pain. Each item served multiple purposes, and each was chosen for its resilience against rust, rot, and the constant dampness of a ship's bilge. The most iconic tool was the amputation saw. It was smaller than a carpenter's saw, with fine teeth, designed for cutting through bone as quickly as possible. Speed was critical, not for the patient's comfort, which was minimal, but to limit blood loss and shock. Alongside it were several knives, from large amputating knives for slicing flesh away from bone to smaller, sharper lancets for letting blood. Trefines, terrifying corkscrew-like drills used to bore holes into the skull to relieve pressure from head injuries, were also part of a well-equipped chest. These instruments were typically made of forged steel and stored in a lined wooden case to prevent corrosion from the salty air. For the work of closing wounds, the surgeon relied on needles and ligatures. The needles were often straight, not curved like modern ones and made of brass or steel. Ligatures were threads of silk or linen used to tie off blood vessels during surgery. Bandages were made from old sailcloth or coarse linen, ripped into strips and sometimes impregnated with wax or tar to make them waterproof. A crucial if humble item was the tourniquet, usually a simple leather strap with a wooden toggle, used to constrict blood flow to a limb during amputation. Adhesives were primitive. Plasters were made from a mixture of resin, wax, and sometimes lead, spread onto cloth. These were used to hold dressings in place or to cover superficial wounds. The smell of these materials, the metallic scent of blood on the tools, the earthy odor of the linen, the sharp tang of pine tar, would have been the first sensory assault on a wounded man brought below decks. The pharmacological side of the chest was where speculation and tradition mingled with observed effect. The most important liquid was not a medicine, but an anesthetic: rum. A large dose was the primary method for dulling a patient's senses before a procedure. For cleaning wounds, vinegar and brandy were used, their acidity and alcohol content providing some antiseptic properties, though the germ theory of disease was still centuries away. Surgeons also carried a variety of dried herbs and prepared compounds. Laudanum, a tincture of opium, was a potent painkiller and sedative, used sparingly due to its cost and addictive nature. Peruvian bark, which contains quinine, was used to treat fevers, particularly malaria, which was common in the Caribbean. Other staples included jalap, a powerful purgative to clear the bowels, and cantharides, an extract from blister beetles used to raise blisters on the skin, based on the belief that drawing out fluids could balance the body's humors. Perhaps the most surprising items were those for dental care and minor surgery. Tooth keys designed to grip and twist out rotten teeth were common. Simple forceps for removing foreign objects, like splinters or musket balls, were essential. Cups for bloodletting, and heated glasses for cupping therapy, which created a vacuum on the skin to supposedly draw out deep-seated illness, rounded out the kit. The chest itself was a physical anchor of order amid the chaos of injury. Its arrangement was deliberate. Every bottle, every blade, had a specific place so it could be found by touch in the dim, swaying light of the ship's cockpit. This arsenal was not about comfort or cure in the contemporary sense. It was a collection of calculated responses to a narrow set of catastrophic problems: hemorrhage, infection, fracture, and fever. Using these tools required a steady hand and a detachment that modern medicine would find jarring. But on the wooden decks of a pirate ship, it was the only barrier between a crewman and a burial at sea. The treatments applied from the pirate surgeon's chest were guided by a medical logic that seems alien today. The dominant theory was that of the four humors: blood, phlegm, black bile, and yellow bile. Health was believed to be a balance of these fluids, and illness was an excess or corruption of one. Therefore, most treatments aimed to remove the offending substance from the body. This philosophy dictated the three primary procedures: bloodletting, purging, and blistering. Bloodletting, often the first response to fever, inflammation, or headache, involved opening a vein with a lancet, to drain what was considered bad blood. The amount taken was significant, sometimes pints, which we now know would weaken a patient already fighting infection. Purging used powerful herbal laxatives like jalap to violently clear the bowels, aiming to expel corrupted bile. Blistering involved applying a plaster containing cantharides or Spanish fly to the skin to raise painful blisters, the theory being that this would draw out deep-seated humors from within. Surgery was a last resort, undertaken only when external treatments failed or for obvious traumatic injuries. The most common operation was amputation, required for compound fractures or gangrenous limbs. The procedure was brutal and fast. The patient would be given a large quantity of rum or, if available, a dose of laudanum. A tourniquet was tightened above the site. The surgeon would use his amputation knife to cut through the muscle down to the bone, peel it back, then saw through the bone with deliberate, rapid strokes. The goal was to complete the cut in under 3 minutes to minimize shock and blood loss. The major arteries were then pulled out with a hook and tied off with silk ligatures. The stump was cauterized with a hot iron or boiling oil to seal the wound, a process believed to prevent infection, but which caused immense additional trauma. Survival depended on the patient's constitution, the surgeon's speed and sheer luck, as the concepts of antisepsis and sterile technique were unknown. For internal ailments and chronic diseases, the surgeon relied on his store of botanicals and minerals. Peruvian bark, or cinchona, was a prized and expensive specific for the intermittent fevers of malaria. Its bitter powder containing quinine was one of the few truly effective remedies in the entire chest. For syphilis, the standard and devastating treatment was mercury. It was administered as a salve, rubbed into the skin, or taken orally, leading to symptoms of mercury poisoning, excessive salivation, tooth loss, and neurological damage. Sailors with scurvy presented a paradox. Their symptoms, spongy gums, loose teeth, lethargy, and old wounds reopening, were well documented in ship logs. Some surgeons observed that these men improved when the ship made landfall and consumed fresh greens or fruits. However, the direct link to a dietary deficiency was not yet established. James Linn's pivotal experiment proving citrus cured scurvy would not be published until 1747, and even then, adoption by the Royal Navy and merchant fleets was slow and inconsistent. On a pirate ship, access to such preventative supplies was entirely dependent on successful raids on provision-laden merchant vessels. Dental care was a common and agonizing necessity. Tooth decay was rampant due to diet and hygiene. The primary tool was the tooth key, a metal instrument with a claw that was hooked over the rotten tooth. The surgeon would turn the key, leveraging the tooth out of its socket, often taking pieces of jawbone with it. For less severe pain, a cavity might be packed with wax or a mixture of herbs. Wound management after battle or accident was a constant concern. Projectiles like musket balls and splinters were dug out with probes and forceps. The wound was then cleaned with whatever was on hand, vinegar, brandy, or simply seawater. It might be packed with lint, scrapings from old linen, and bandaged. The smell of a healing wound, a mix of pus, decaying tissue, and the vinegar or tar used as dressing, was a pervasive part of the sick berth's atmosphere. The treatments of the Golden Age were a mixture of observed, accidental efficacy and deeply flawed theory. They were applied with a pragmatism born of dire circumstances, where the alternative to a painful and risky procedure was almost certain death. The surgeon's role was not to guarantee recovery, but to offer a chance, however slim, and in doing so, maintain the crew's fragile belief that they were not entirely at the mercy of the sea. The legacy of pirate medicine is not a story of great discoveries or heroic breakthroughs. It is a quieter, more practical inheritance. The true impact lies not in what these surgeons knew, but in how they operated under impossible constraints. Their world was a brutal laboratory, one where the consequences of every decision were immediate and irreversible. The knowledge gained on those wooden decks, often through failure, slowly trickled into the broader stream of medical practice. The most direct legacy was the standardization of emergency surgical techniques. The pirate surgeon's emphasis on speed, on the use of the tourniquet, and on the systematic, if crude, cleaning of wounds became foundational principles for battlefield medicine. These were not theoretical refinements. They were hard-won lessons from countless amputations performed in rolling, dark, and bloody cockpits. The practical needs of maritime medicine also pushed forward the understanding of nutrition and disease. The high incidence of scurvy on long voyages created an undeniable pattern that forced attention on the problem. While James Linn's controlled experiment in 1747 is rightly celebrated, it was built on a century of anecdotal reports from ship surgeons who noticed that men eating certain foods recovered. These were not academic researchers. They were practitioners who recorded their observations in ship logs and journals. Their notes, filled with desperate attempts and unexpected successes, provided the raw data for later systematic investigations. The eventual adoption of citrus juice as a standard naval ration was a direct consequence of this accumulated evidence, marking one of the first large-scale public health interventions based on empirical observation. However, the legacy is also a cautionary tale. The pirate surgeon's toolkit was filled with treatments that were not just ineffective but actively harmful. The dominance of humoral theory, with its reliance on bloodletting, purging, and blistering, persisted for generations. These practices, which drained patients of strength and fluids, were not abandoned until the late 19th century, when germ theory and cellular pathology provided a new framework. The persistence of such dogmatic treatments, even in the face of evidence that they often killed patients, is a sobering reminder of how authority and tradition can override observation. The pirate surgeon was trapped by the limits of his era's knowledge, but he was also a product of it, and his failures were as instructive as his successes. The most surprising legacy is perhaps in the realm of crew management and public health. Pirate ships, by necessity, developed a rudimentary form of triage and quarantine. A man with a contagious fever was often isolated. A severely injured man was given a clear if grim prognosis. The crew's survival depended on the surgeon's ability to make quick, unsentimental assessments about who could be saved and who could not. This brutal pragmatism prefigured the mass casualty protocols used in modern field hospitals and disaster response. The system was not humane by modern standards, but it was functional within its context. It recognized that resources were finite and that the group's survival sometimes required difficult individual sacrifices. Modern medicine still grapples with the core challenges that defined the pirate surgeon's world. Infection control in austere environments, trauma management in the field, and the treatment of diseases in resource-poor settings. The parallels are direct. Military medics in remote outposts, humanitarian doctors in conflict zones, and emergency physicians in overwhelmed hospitals all face the same fundamental problem: how to do the most good with very little. The pirate surgeon's solution was not elegant, but it was effective within its limits. He used the tools he had, applied the best knowledge available, and made decisions with a speed and clarity that came from constant practice under pressure. That is a legacy that transcends the centuries, a reminder that the core of medicine is not a sterile laboratory or a complex machine, but a human being making a decision in a moment of crisis. The contents of the medicine chest have changed beyond recognition, but the hands that open it are still guided by the same desperate hope, the same need for speed, and the same unyielding commitment to pull one more soul back from the edge.